Saeed Hamid. He is Professor of Gastroenterology, Department of Medicine. He is also the Director, Clinical Trial Unit at Aga Khan University. Amongst Best Teacher Award, Faculty Development Award, Outstanding Speaker Award, he has many achievements to his credit. Professor Saeed is not in the hall. I think he's just stepped out for a minute. Yeah, we'll just... Ji. Ji. सर हो रहा है अभी यहाँ पे भी अब कर रहे हैं जी सर सेकंड स्पीकर डॉक्टर काशिफ शाजली जी सर की पहले करवा देते हैं टॉक आगे अच्छा So we welcome Professor Saeed Hamid. He is Professor of Gastroenterology, Department of Medicine at Aga Khan. He's also the Director for the Clinical Trial Unit, and amongst Faculty Development Awards and Best Teacher Awards, he's got much achievements, many achievements to his credit. So please, you may take over for your talk. Thank you.
ये गलत प्रेजेंटेशन आ गई भाई गलत प्रेजेंटेशन आ गई नहीं यार ये इसको लगाएं Can I put it here? इधर लग जाएगी सुबह नोट यही करो इधर नहीं वो चल छोड़ ये वाली जी पहली वाली थैंक यू सो मच इसको स्लाइड शो पे कर दें बिस्मिल्लाहिर्रहमानिर्रहीम थैंक यू फॉर द काइंड इनविटेशन आफ्ताब मोहसिन साहब अगर ये टॉक भी उसमें एस्पिरिन सिम्पोजियम में डाल देते तो शायद को ऑडियंस ज़्यादा बेहतर होता है यहाँ पे राइट बिफोर वी स्टार्ट वी नो कि नेफल्ड के पेशेंट्स की द नंबर वन रीज़न फॉर मोर्टेलिटी इज़ कार्डियोवास्कुलर डिजीज़ एंड नॉट फैटी लिवर डिजीज़ तो ये बिल्कुल फिट हो सकता था एस्पिरिन के सेशन में बट एनीवे हुएवर इज़ हियर it is a pleasure to talk to you. I will just give you brief updates. It is not possible to give a whole talk in 20 minutes on NAFLD. जो recent जो developments हैं उसके बारे में बात करेंगे. I have no disclosures relevant to this presentation, but I will talk about off-label use of some medications which are not yet approved for treatment. This is the menu. We'll talk about the prevalence. There is a name change debate going on, as many of you may know already. There are new thoughts on pathogenesis. There is a condition called lean NAFLD, which is different to what we typically understand as NAFLD. The clinical picture, the newer drug therapies, role of bariatric surgery, and multidisciplinary approach. Now, just very briefly, prevalence. This is a highly prevalent disorder. These figures that you see here are all population-based studies from different parts of the world. And they clearly show that the prevalence of NAFLD is very, very high. We are in the 20 to 30% range, which means that 20 to 30% of our population has some form of fat in their liver. It may not necessarily be NASH, but it certainly is present. This is some data from Pakistan that we have been able to collect, and these show that the general population figures are 20 to 30%. We have at least one good population-based study from our university in Karachi where this figure applies. If you look at individuals who are at risk of diabetes mellitus, for example, the Indian diabetes score, risk score is more than 60, 60% of these people will have fat in the liver. We know that individuals with type 2 diabetes mellitus, 70 to 80% of these patients will have fat in the liver, some form of fatty liver disease. And we also know that nearly a quarter of our population suffers mainly from type 2 diabetes. So you can put these figures together and understand what is the burden of disease of NAFLD in our country. Now, there has been recently a controversy and a debate that is going on. And that is changing the name of NAFLD to MAFLD. And MAFLD stands for Metabolically Associated Fatty Liver Disease. Now we also know that the metabolic syndrome plays a key role in the pathogenesis of NAFLD and how we approach it, and therefore this controversy has started. But if you look at the chronology of nomenclature, this has gone through many iterations, right from 1938 when it was called fatty infiltration of the liver. Then somebody said hepatic steatosis. This must obviously be a pathologist who named it hepatic steatosis. Then we came to non-alcoholic liver disease, then fatty liver, and finally in 1986 we came to non-alcoholic fatty liver disease. And that name has stuck so far, and now there is the objections that are coming to this name. And what are those objections? The objections are that when you talk about NAFLD, it becomes a disease of exclusion. So you're saying this is not alcohol, but this is fat, right? So this is not alcohol-related fat, but this is still fat in the liver. So it is a disease of exclusion instead of being defined as a disease of inclusion, which metabolically associated fatty liver disease will serve the purpose. Secondly, NAFLD is a vastly heterogeneous entity and cannot be managed as one single condition because it's an umbrella kind of a nomenclature which covers many aspects of fatty liver disease. NAFLD patients do consume some alcohol, particularly in the West. There is nobody that is almost entirely alcohol-free, people who present to your clinics, and the impact of alcohol is certainly under scrutiny in what we call NAFLD. The word non, for some people, trivializes the problem, while the word alcoholic demeans the patient. So if you say you have non-alcoholic fatty liver disease, that means we don't know what you have, number one, and number two, we know that you do not drink alcohol or whatever. So it kind of demeans the patient. But there are some issues with MAFLD as well. So what MAFLD does is emphasizes the underlying condition of systemic metabolic dysfunction, right? And there is certainly a need for a greater homogeneity so that the treatment, the diagnostic parameters, etc., can be geared towards that homogeneity, which the term MAFLD or the name MAFLD provides. And we all know the metabolic syndrome components: obesity, glucose intolerance, hypertension. I don't need to repeat that to this audience. And therefore, this is what the definition of MAFLD is based on. However, I think there is always a need for some caution. And it may be premature just to immediately jump to the name of MAFLD rather than stick with NAFLD. For example, 95% of papers that have been published so far in the world explicitly use the term NAFLD and NASH. MAFLD is only very recent. So what do you do when you start writing a review recently for a book chapter, and the editor came back to me and said, you are totally confused because somewhere you use NAFLD and then you go on to using MAFLD. What is going on here? And I said, well, look, I can't give you a reference which typically says MAFLD. So I have to give you a reference which says NAFLD, but by implication mean it to be MAFLD. So those are some of the difficulties that we are encountering when we change these names immediately. So there's a debate going on, and therefore, hopefully, this will be settled within this year, hopefully. Now, we also know that NAFLD is not always based on metabolic syndrome, right? There may be some people who do not have insulin resistance and yet have fat in the liver. What do we do about those? When we label NAFLD, we become homogeneous. But what about the outliers? For example, fatty liver disease due to TPN, let's say, which we know is a distinct entity, and it is a very common problem with TPN patients, and a very difficult one to look at. So these are some of the issues. The genetics may be different. In subjects with PNPL3 polymorphism, steatosis occurs independent of insulin resistance and serum lipid concentration. So when we make the name change, we will need to consider the genetics as well. The term, so we did a small survey. This is part of a larger group that we work with, and we said the term NAFLD indicate this is a question to the patients. The term NAFLD indicates that you have fatty liver disease without drinking alcohol. Does this label console you, or is it disrespectful? Surprisingly, the patients don't mind this label. They say it consoles me because it immediately tells people that I don't drink alcohol, and therefore my problem is not alcohol related. So to summarize it all, metabolic syndrome is a major part of NAFLD. However, there's much more to NAFLD than meets the eye. The word metabolic in NAFLD would be a rejection of the scientific evidence gathered on NAFLD pathogenesis. As I've mentioned, much of the literature relates to NAFLD and not to MAFLD. Change of nomenclature may not address the issue. If we hurry it, it could paradoxically misdirect therapeutics. So this name change will come, but I think it has to be elaborated a little bit more, and it will that will make sense. We know about the pathogenesis so far, the multiple hit theory, the insulin resistance, the cytokine milieu, the adipokines, etc., etc. But what is new is the role of the intestinal microbiome, which modulates insulin resistance and metabolism, and therefore contributes to the accumulation of fat, not just in the liver, but in the adipose tissue, in the muscle, and so on and so forth. I missed the talk yesterday from Professor Aziz Rahman, and I was asking him to please send me his slides so that I can complement this talk with his slides a little bit more. I don't have too much time to elaborate on the role of the microbiome, but this seems now fairly critical in terms of whether people develop the fatty liver disease or not, despite the risk factors, and therefore this is important. We know that NAFLD is associated with gut dysbiosis, and NAFLD has been found to be associated with reduced abundance of several bacterial species, independent of BMI and insulin resistance. NAFLD patients have higher concentrations of select fecal and serum metabolites, indicating a specific intestinal micro community. So there is work that needs to be done in the role of microbiome in the development of NAFLD. Now, lean NASH is something which is intriguing because these patients do not get obese. These are not obese patients. In many cases, they are sort of even underweight. Our Asian population, the classical BMI or the standard BMI is 23 or less, and these patients may be 23 or less, and yet they have fat in the liver. However, the important thing is that these patients have less severity of their histological issues, for whether it is steatosis, whether it is lobar inflammation, whether it is ballooning, or whether it is fibrosis. Nonetheless, some of these people can even progress to full-blown fatty liver disease and complications of fatty liver disease. What is the difference? And the difference again seems to be the compensatory mechanisms, which include increases in bile acids and FSR activity and distinct gut microbiota profile. So we cannot get away from the microbiota of an individual when we talk about the pathogenesis of NAFLD anymore, I think, because it seems quite clear that patients who are so-called lean NAFLD have a different microbiome than what the obese patient will have, so that they do not develop obesity, and therefore they do not develop many of the manifestations of fatty liver disease. The clinical picture is known to everybody. I'm not going to take too much time on this, except to say that in our practice, in the liver GI practice, NAFLD related cases are on the increase. This is data from 1998 to 2016, and you can see there is almost 100% increase in cases of NAFLD that we see in our clinics, whereas hepatitis C is going down, hepatitis B has gone down and has stayed stable, because we have treatments for these conditions which will cure the disease in case of hepatitis C, for example. So for the foreseeable future, until we find specific cures, NAFLD is going to be the biggest challenge and the biggest group of patients that gastroenterologists and hepatologists will feel. What is more important is now the concept of patient-reported outcomes. And this is highly relevant for NAFLD, because many of these patients may not have very overt symptoms. They may not. Many of the patients, as you would know, present with their ultrasound report in their hand to say, "Doctor, I have fat in my liver. What am I going to do?" They may not have any symptoms. So we are part of a large group, and this is a global study that we did, and data clearly showed a significant patient-reported outcomes burden. For example, clinically overt fatigue is very common among NAFLD patients, which destroys their quality of life to a great significance, so that they lose work productivity and they lose a generally productive life. So please remember, and there are good, very good questionnaires that are available to look at patient-reported outcomes. This is becoming much more relevant for many of these chronic illnesses that we talk about, rather than just a direct history taking and a direct question and answer session with the patient. This is now something that we need to think about. Newer drug therapies. Unfortunately, I don't have to report anything very significant in this. There have been lots of trials and tribulations and so on. Nothing is approved as yet for NAFLD. So when we talk about drug therapy, we talk about off-label drug therapy and not therapy that has been approved by any of the stringent regulatory authorities like the FDA and so on. Now, the issue is that all clinical trials have been done for 1 year, and we know that NAFLD does not last for 1 year. We know that, like hypertension, like diabetes, this is a lifetime phenomena. So what we're trying to do is, after 1 year, we are trying to look at NASH resolution. We are trying to look at improvement in fibrosis, which may or may not be there, which may be too early, or which may happen if you prolong therapy. Any trial that you see of NAFLD has been done only for a year, which doesn't really make sense, because then you do a biopsy before treatment, you do a biopsy 1 year after treatment, things don't change. You say, oh, well, this drug doesn't work, so just leave it alone. Or this drug works a little bit, let's see how it goes. So that is the difficulty. Those surrogate markers are not very good markers. Having said that, there are some definitive interventions that have been done and that show that NASH is reversible. For example, bariatric surgery in severely obese patients with biopsy-confirmed NASH, quite a good number, 180. And you can see that as the weight loss goes on, you have a significant resolution of NASH without worsening of fibrosis. And this is fibrosis. So the baseline, very little F0, which means no fibrosis, to a large chunk 5 years down the line, where there's a significant number which has no fibrosis. So if you follow these patients up with definitive therapy and follow them up, they will improve their status in terms of the liver histology. We know that reversal of NASH improves fibrosis scores. So this is the first biopsy and this is the second biopsy. So F0 goes from about 15% to 60%, which means 60% of these people do not have any fibrosis in the liver following these therapies. This is a long list of drugs that are under development. I would say under development because nothing is approved. And when you see a long list, you can immediately make out two assumptions. One, that nothing very much works. And secondly, that this is kind of a fishing experiment that people are doing and testing, throwing everything at these patients and see what will work and what will not work. Well, some things we know work. Obeticholic acid has been talked about a lot. It is an FXR agonist which alters the bile acid composition and looks at and alters the free fatty acid composition, and therefore reduces inflammation. Lipid metabolism gets better, carbohydrate metabolism gets better. But the drug has significant side effects like itching, for example, like hyperbilirubinemia, for example, and therefore it has not yet been approved, although the initial papers were treated with a lot of optimism. The drug has still not been approved for general use. So what we are left with is something as simple and cheap as aspirin, and that is vitamin E. And this is the famous PIVENS trial, which was reported in New England Journal by Sanyal and colleagues in 2010. And in the orange is pioglitazone, in green is vitamin E, and both pioglitazone and vitamin E reduce steatosis, reduce inflammation, reduce ballooning, reduce NASH over a period of 1 year only. So whereas this is placebo, and this does not move. So almost equivalent results of vitamin E to pioglitazone. Of course, both drugs have issues. Pioglitazone causes fluid retention and therefore weight gain, etc., etc. Vitamin E, there is a safety signal in terms of developing prostate cancer. So if you use vitamin E, please do not use it continuously for a long period of time. Use it for 6 months, give a break, then use it for 6 months, and so on. This brings down the ALT levels, this gets the NASH better, and so on, but be aware of the safety signals. The latest developments have been what are called the GLP-1 agonists, and these have been used in people not necessarily with diabetes, just with fatty liver. Most of them, of course, may have some diabetes. And there is liraglutide, which again shows you in green is the liraglutide, in dark green is the placebo, and across the board you can see that there are significant benefits of liraglutide, 1.8 milligrams per day. And the same goes for semaglutide, which is once a week injection and gives you the same results as liraglutide. So this is something that one can look forward to in terms of approvals, that liraglutide or semaglutide does get approved as therapy for NASH. So I've just talked about this. And then coming back to the basics. And the basics are weight loss. And if you lose weight, this is how you go. So if you lose more than 10% of your starting weight, your resolution, 97% of the patients will resolve the histological changes of NAFLD. Of course, this weight loss has to be maintained. Everything will come back if the weight is, and 10% is a significant amount of weight loss to lose. But however, if this is done, this is still the best therapy that you can use. And weight loss is associated with improved NASH outcomes. We know that the complications of liver disease, the progression to fibrosis, and so on, all is made better with significant weight loss. Finally, the role of bariatric surgery. And exactly the same thing happens as it happens with weight loss, except that this is a one-time intervention. Many people are now touting it. The surgeons are saying this is anti-cancer therapy because it prevents liver cancer, it prevents gut cancer, it prevents this. I'm not sure if I'm willing to go that far with my patients to say that let's have this anti-cancer therapy, but certainly this is something which will work for people with morbid obesity and with fatty liver. So everything goes down, steatosis goes down, inflammation, fibrosis, ballooning, everything goes down. The biggest advantage is that fibrosis goes down significantly, which is the really what you want to achieve with these things. My last point, and that's an important one. I hope that there is a mix of crowd here, and therefore we need to address this multidisciplinary care in NAFLD patients. This is the key to success. It is not just the hepatologists or liver doctors or GI people who should be seeing and dealing with these patients. It should be across the spectrum. The endocrinologists, the general physicians, the internists, everybody has to have a stake in this. Otherwise, we will not get anywhere, because I showed you the burden of disease is enormous, and it will continue to rise as we go along, and a lot of us develop diabetes. So again, from that group that we work in, we did a global survey of physicians. This was about 20,000 respondents 2,000 respondents that we looked at. Even in this survey, hepatologists were seeing the greatest number of NAFLD patients, 150 versus 10 for primary care physicians, right? This ratio has to change. Otherwise, we will get nowhere. There is a much larger group of primary care physicians in anywhere, even in this country, than there is a group of hepatologists. Hepatologists cannot just cope with those numbers. They need help. The primary source of NAFLD knowledge acquisition for hepatologists were international conferences, but for the PCPs, it was the internet. The second most common was, they were looking at guidelines, of course, but the second most common was the internet. So despite the growing burden of NAFLD, a significant knowledge gap remains for the identification, diagnosis, and management of NAFLD. And this is a paradigm that we need to shift. And Professor Akram is here, other members of the PSIM are here. I think this is something that we should focus on. I'm a past president of the Pakistan Society for Study of the Liver Disease. On behalf of the PSSLD, I invite PSIM and the diabetes group of the PSIM particularly, and also the primary care physicians. We have the College of Family Physicians here in Karachi who are sitting there. We have the Pakistan Endocrine Society, which is here. These 3 or 4 societies should get together and develop the next guideline that is released by all of these 4 societies simultaneously. Thank you very much for your attention. I just want to conclude with my last, just to reiterate the messages. NAFLD-NASH is the commonest chronic liver disease that we see now and will see in the future. Not just hepatologists, but everybody across the board. The basis for most NAFLD is the metabolic syndrome. However, it is a heterogeneous condition with many manifestations, such as lean NASH that I showed you. The gut microbiome may be a central player in determining the clinical severity of liver disease. So I think this is something that we can work on. Aziz bhai, कि gut microbiome का क्या role है? हमारे gut microbiome का क्या role है NAFLD के अंदर? Drug therapies remain elusive as they do not alter the basic pathophysiology of the disease and therefore will not be sufficient in the long term. Despite the growing burden of NAFLD, a significant knowledge gap remains for the identification, diagnosis, and management of NAFLD in many of our categories, like the primary care physicians, endocrinologists, even endocrinologists, and internists, etc., etc. Thank you.